As I said, it is important to be aware about the various levels of subdivisions that you can do with respect to the cortex. The easiest, simplest are the surfaces, then you have the lobes, then the gyra and sulci, and finally the cytoarchitectonic fields. And this is where really the fusion of functional and anatomic areas comes together. But it is very difficult to access this by imaging, with a very few exceptions, and I'll mention some of them. So the surfaces, we have three. One is the medial surface, then you have the lateral or the convexity surface, and then you have the inferior or the basal surface. Already by saying there's a lesion on the inferior or convexity surface, you convey an information that is unequivocal and clear. In terms of the lobes, and if you think briefly, what is the number of lobes that we have, then the current concept is 4, 5, 6. These are the answers that I usually get when I ask the question. So the right answer, the correct answer is 6. We have 6 lobes in each hemisphere: frontal, parietal, temporal, occipital, and then not to forget the insular, and of course not to forget the limbic lobe. So these are 6 lobes. In the late 90s, Yashagil suggested to take the precentral gyrus of the frontal lobe and the postcentral gyrus of the parietal lobe and take them together to form the so-called central lobe. It's a very good suggestion from an anatomical physiological point of view, but it was not taken up, and the division stays that we have 6 lobes per hemisphere. So when we talk about lobes, we need to be aware about the borders, the subdivisions. And here are images from 4 different textbooks. And you see that with respect to frontal and parietal, they all mention the same structure, and that's an anatomic landmark, an anatomic structure, which is the central sulcus. When you come to the anterior border of the occipital lobe, it is also well defined, but it is not an anatomic line, it is an artificial line which connects 2 different anatomic points with each other. One is here. It is where you just see the end of the so-called parieto-occipital sulcus from the medial surface, just getting over to the convexity and then coming to be seen just very slightly at the convexity. Then you have here inferiorly the so-called pre-occipital notch, and when you connect the 2, you have the anterior border. When you then come to the border between parietal and temporal, you have anteriorly and an anatomic landmark, which is the Sylvian fissure, which very clearly separates parietal from temporal, and then you have a not well-defined line. As you see here in Ono's book, he took a line that makes a 90-degree angle. Talarach here just extended the line horizontally until it meets the anterior border of the occipital lobe. Testu just extended very nicely the line posteriorly. Damasio did not give a clear definition of how the border should be identified. So it is important to know that there is no clear definition, no agreed on definition about where a structure would be lying exactly. And actually, I don't think it's really important. It is important when you deal with structures that are very clear, like the central sulcus or the Sylvian fissure. So talking about the lobes of the convexity and the borders, we said frontal, parietal, occipital, temporal, and the borders were just mentioned and should be clear. On the medial surface, you have the frontal, parietal, temporal, occipital, and now the limbic lobe. The limbic lobe you can see as it goes around. We'll speak about that in a second. The border between frontal and parietal should be the central sulcus. That's not very clear on this image. Between parietal and occipital, it's the parieto-occipital sulcus. Between occipital and temporal, you have again an artificial line connecting the pre-occipital notch with here the connection of these 2 sulci, which are the calcarine and the parieto-occipital. When I talked earlier about the pre-occipital notch, it's a nice paper here that you see, the work of, where you have the brain, you have the dura, and you see a dural fold causing this indentation into the brain, and usually also you have here a vessel. So this is why if you give contrast, whether it's CT or MR, you have an enhancement of the vein, and usually at the area where you have a thickening of the bone. So this can give you a landmark where you can see where the border would be between temporal and occipital. Now, leaving the lobes and looking at the gyri and sulci within a lobe. And if we think about them, we need to have an abstract, an idea in our mind how this should function. Every brain is different from the other. It's almost like a fingerprint. You will never have the identical sulci and gyral pattern between one person and the other. They will always be different. So a suggestion, according to Duvernois, and that's from his book, would be that in the frontal lobe you have an order of 3 + 1, which means 3 longitudinal gyri and 1 transverse gyrus. The 3 longitudinal would be very simply superior frontal gyrus, middle frontal gyrus, and inferior frontal gyrus, and they're separated by 2 sulci, superior frontal sulcus and inferior frontal sulcus. The transverse one would be the precentral gyrus. Very simple, 3 + 1. You move then to the temporal lobe, the same applies, 3 + 1, and a similar nomenclature prevails. So you have the superior temporal gyrus, the middle temporal gyrus, and the inferior temporal gyrus, and you have 2 sulci, the superior temporal sulcus and the inferior temporal sulcus. And then you have your transverse gyrus, which is Heschel's gyrus, which is located here. So frontal and temporal is 3 + 1 on the convexity. The occipital, it's only 3, and you have similar scheme, superior occipital, middle occipital, quite large, and inferior occipital gyrus. No transverse in this case. The parietal lobe is different. The parietal lobe constitutes of, on the one hand, the post-central gyrus, and then 2 lobules. A superior parietal lobule here, which is just one, if you want to say, one chunk of tissue, and then you have the inferior parietal lobule, where you have 2 gyri, one anteriorly sitting like a horseshoe, as described by Tom Nadick. You have a horseshoe on the sylvian fissure, that's the supramarginal gyrus, and then you have a second horseshoe sitting on the superior temporal sulcus, and that is the angular gyrus. The sulcus that is between P1, which is superior parietal lobule, and P2, which is the inferior parietal lobule, is a very important and deep sulcus, which is because it is separating between 2 parietal lobules. It's called the intraparietal sulcus. On the medial surface, the frontal lobe, you have the gyrus rectus, and then the superior frontal gyrus, and then you have a structure that's called the paracentral lobule. The anterior part of it belongs to the frontal lobe, and the posterior part belongs to the paracentral lobe, to the parietal lobe. You then have the second structure in the parietal lobe is then the precuneus, which is this here. You then move to the occipital lobe, and the occipital lobe is quite important on the medial surface. So you have here, the next structure would be the cuneus, between the parietal occipital sulcus and the calcarine sulcus. And then below it, it's so-called lingual gyrus. We'll speak about that later. Then we come to the limbic lobe, and very roughly, because this is not what we'll be speaking about this time, you have the so-called limbic gyrus, which goes around here, and then you have the intralimbic gyrus, which includes structures such as the hippocampus itself and the dentate gyrus. Coming now to the inferior surface, you have the frontal lobe, where you have the gyrus rectus, which you just see here, olfactory sulcus, and then you have 4 orbital gyri. And it's very simple. You have a medial orbital gyrus, a lateral orbital gyrus, an anterior orbital gyrus, and a posterior orbital gyrus. So 4 orbital gyri separated from each other by an H-shaped sulcus. And then the posterior part of the inferior surface, here you have the temporal and occipital lobes, and because there is no clear anatomic line separating them, quite often it's spoken about the temporal-occipital lobe of the cervix. It's of course inaccurate, but you will find this sometimes in the literature. So you have three gyri, the inferior temporal and occipital gyrus. You have the fusiform and the parahippocampal and lingual gyri. Very well demonstrated and easily identified on coronal images. So if you start here, for instance, with the sylvian fissure, you have here the superior temporal gyrus, the middle temporal gyrus, and the inferior temporal gyrus, which makes just the corner. So you see it both at the convexity and you see it also in the inferior surface here. And then you come to a very broad gyrus, which is the fusiform or the lateral occipitotemporal gyrus. And then finally, you come here to the parahippocampal gyrus, which together with the lingual gyrus behind it form the so-called medial occipitotemporal gyri. And not to forget, you see also Heschel's gyrus, and we'll speak about that in a second. Now, after this overview, let's start with the area that's really important in the clinical setting to identify correctly, the central region. It is important because here you have the functional organization and representation of motor and sensory systems in the form of a homunculus. So you have the precentral gyrus, where you have the motor homunculus, and you have the postcentral gyrus, where you have the sensory homunculus. You can think of the central region as a kind of an ellipse, where you have anteriorly the precentral gyrus, you go superiorly to the paracentral lobule, posteriorly to the postcentral gyrus, and then inferiorly the subcentral gyrus. So here on the image, if you start, you could start here, the subcentral, go up precentral, go back paracentral, and then postcentral gyrus. And in the middle of that, you have the central sulcus. Trying to identify this has been always important. There are anatomic methods, there are functional imaging methods. We will concentrate on the anatomic methods and mainly on MR, and many of this applies also to the CT. So when talking about anatomic methods, we can subdivide them into methods using extracerebral landmarks and those using cerebral landmarks. Extracerebral landmarks are landmarks like the coronal suture, which you can feel if you put your hand on your head and move it a little bit. You can feel the coronal suture where it is, and we know that the coronal suture is about 1.5 centimeters anterior to the central sulcus. That's an information that could help neurosurgeons to plan, and did it for quite a long time, if they don't have navigation systems. Cerebral landmarks, which is much more important to neuroradiologists, you can subdivide again into deep and cortical ones. The deep are using, for instance, here the anterior commissure and posterior commissure lines. Have a quick look, think where it is, and there you see it. So the connection between AC and PC, and then you can do lines, perpendicular, parallel, and so on, subdivide the whole volume of the brain, and then assign a certain area to the central sulcus. This works reasonably well for areas which are quite close to this ACPC line, but the further you go away, the more unreliable it becomes. So what I want you to be left with at the end is knowing these landmarks. So you have 4 axials and 3 sagittal landmarks, and we'll go through them now. So the first one, it was the first one that was described by Kido in the 1980s using CT, is the so-called L sign. L is how Stefan Sunart from Leuven then called it. So you start very simply with the midline. You go then laterally, and the first sulcus would be the superior frontal sulcus. The sulcus that meets it in a near perpendicular way would be the precentral sulcus, and behind it you have the central sulcus. So 3 steps, and there you are. It works quite nicely. Let's try it here. Midline, superior frontal sulcus, precentral sulcus, precentral sulcus, and then the central sulcus behind it, and that's a cavernoma in the post-central gyrus. Similar here, you have the midline, superior frontal sulcus, precentral sulcus, and then the central sulcus and a hematoma from a cavernoma in the postcentral gyrus again. So pretty much straightforward, but like always, and this is why we need more landmarks, a number of landmarks, a number of methods, is you have variations. You can have an additional sulcus between midline and superior frontal sulcus in 2/3 or 3/4 of the cases. It's often not a problem because it doesn't go very deep, but it can be confusing. The superior frontal sulcus is uninterrupted in only 1/3 to 40% of cases. Quite often you will find a connection actually between the superior frontal sulcus and the central sulcus, which can make it difficult. The second landmark is the knob, the omega, or the epsilon sign, also the motor hand area at the middle genomedius of the central sulcus. If you do functional imaging of a number of volunteers and pool the information onto the MR, you will see that they usually focus here on one protrusion of the precentral gyrus. This protrusion is where you have the location of the motor hand area. You can see it in anatomic specimen, and you can see it here in Tarek Atlas. To note is that this omega, or the knob, or the motor hand area, is opposite to the intersection of the superior frontal sulcus with the precentral sulcus. When you look at this one and try the method from Kido, the L sign, you have here the midline, superior frontal sulcus, precentral sulcus. Would that be the central sulcus? No, it wouldn't. You look here at the omega, you look at the hand area, the knob, and you see immediately this must be the precentral gyrus. This here must be the precentral gyrus. Sometimes, like in this case, you see a doubling, and then we call this an epsilon sign, and you see it here, an epsilon sign. Can be problematic sometimes if you have here a sulcus that goes through the precentral gyrus, then you get the feeling almost that there were 3, but there are 2. If you get an infarction within it, subcortical infarct here, then you get an isolated paresis of the hand. The infarct can be subcortical or can be cortical, as you see here. It will lead to the same clinical manifestation. Usually the patients recover well from this within 10 days or so. So, looks like an omega 90% or epsilon 10%, others at 75 and 25, usually opposite to the junction. In the sagittal plane, looks like a hook, we'll see that in a second, and it has been published that neurosurgeons can use it as an intraoperative landmark too. Variations, of course, you can have the impression of a second knob or motor hand area in the postcentral gyrus, and sometimes you have a bridge actually rather than a knob. So this is the variation we saw a moment ago, but here you see the precentral and the postcentral. There is no knob, but there's a bridge. It was called by the French anatomist the pli de passage. And here you see 2 hooks. The first one, of course, is the precentral gyrus, and the second one is the postcentral gyrus. So let's come to the third method, which uses characteristics of the precentral gyrus itself. So the gyrus itself is thicker. The precentral gyrus is thicker than the postcentral gyrus in 98%. You sometimes can see it of equal size, it's very unusual, and to see it smaller the other way around would imply pathology. You also realize that it's not only the gyrus that's thicker, but using the appropriate sequences at 1.5T, as it was published here, you see that the cortex is also thicker here than there. Maybe even better seen here, where you see this is the cortex and this is the cortex, and this is thicker than this here. At 9.4T, you see that this is central sulcus, and the real difference between the two, and it is at the bottom of the sulcus that you have the biggest change in thickness of the cortex across the whole surface of the brain. Where could that be relevant? It could be relevant if your anatomy is distorted and if you don't see anything really but the central sulcus. So you will need a pathology that changes the signal is just of the white matter and not of the cortex. And this happens, for instance, with vasogenic edema, radiation related changes, and so on. So in this case, you see nicely, we've got the white matter on this T2 image. The white matter is white, the gray matter is gray, and you see this is clearly thicker than this one. Looking at this one and looking at these two sulci, here magnified, these two sulci, these are quite close to each other. This is clearly thicker than this one. This is why, if I only see these two, I would have to say that this can but be the central sulcus, where this cannot be the central sulcus. So that's a very nice way of looking at it. Another thing is looking at the signal intensity on FLAIR images. And this is a nice paper from Turkey published in Radiology, where they showed that the high signal is in the frontal lobe, in the cortex of the frontal lobe, and the parietal you don't have a high signal. And the first sulcus where you have this change, where you have the cortex not bright, but iso or hypo-intense, is the central sulcus. So you can see here the hyperintensity of the cortex, and here it stops. Very nice way. The fourth and the last method comes from the back, from posteriorly, and looks at this structure here, which has been coined as being the pars bracket. And the sulcus, the rule is that the sulcus that goes into the pars bracket is the central sulcus. And Tom Nadick showed in his publication that how to identify this pars bracket is by looking at its form and how it changes. If you are further down, further inferiorly, it looks like a droopy moustache, and then it looks here like a straight one, and then it moves slightly up until it's nicely formed, as he always mentions, the Salvador Dali moustache. Let's go now to the sagittal landmarks. We have three, one on the medial surface. Here you have the corpus callosum, the sulcus of the corpus callosum, the cingulate gyrus, and the cingulate sulcus. Now the cingulate sulcus goes backwards, upwards at the ramus marginalis. Anterior to the ramus marginalis is the central sulcus. So this small notch is the central sulcus. This is what we have to identify. Looking here at the specimen, corpus callosum, sulcus of the corpus callosum, cingulate gyrus, cingulate sulcus, C-shaped, goes backwards, upwards at the ramus marginalis. Anterior, you have the central sulcus. Let's try it here. Corpus callosum, we don't see the sulcus very well. Cingulate gyrus, cingulate sulcus is interrupted, goes up here at the ramus marginalis, and then you have here the central sulcus, a small notch. The same here. Corpus callosum, we don't see the sulcus of the corpus callosum very well, but we see the cingulate gyrus, we see the cingulate sulcus, which is interrupted a number of times until it goes up here at the ramus marginalis, which is widened, and then you have here widened central sulcus. The second, the one I mentioned before, which is the motorhand area, which in the sagittal plane looks like a hook. If you look here at the level of the insula, you have posteriorly directed hook. If you move your fist, open and close your hand, you get activation in this area. You see it here at the level of the insula, posteriorly directed hook, and you see it here in Tallerach's atlas. The third method on the convexity, so we had one on the medial surface, we had one in the middle, and now the convexity. It's a bit more complicated, just because it involves more steps. So you have the Sylvian fissure, this is where you start from, that's always the easiest. Once you have the Sylvian fissure, you identify two rami. The anterior horizontal, which may not always be completely horizontal, and the anterior ascending. They have the shape of a V. The next structure you should identify is the inferior frontal sulcus. Once you have identified the V and the inferior frontal sulcus, you see the shape of the inferior frontal gyrus, which has the form of an M. Slightly distorted, but you can see it. Behind the M, you have the precentral sulcus, which is typically interrupted by a junction between the middle frontal gyrus and the precentral gyrus, and then you have the central sulcus. So it's not really very difficult. It's just following, remembering, and then following those steps. Let's try this here. Have a look at it. Sylvian fissure is about here. So we'll be looking here at the V. And then above it, the inferior frontal sulcus. This now shows us the delineation of the inferior frontal gyrus, which would be the shape of an M. Behind the M, we have immediately the interrupted precentral sulcus, and then behind it, the central sulcus. Let's look at this hemisphere. You see the differences in shape. Sylvian fissure again. This should be our V. This is then the inferior frontal sulcus. Then we should have here the precentral sulcus, and this would be our central sulcus. Yeah? It's just a matter of training and using easy cases first, because you will always have abnormalities or variations. Here, for instance, your V, this one, doesn't stop, it just communicates with the inferior frontal sulcus. The inferior frontal sulcus is interrupted by a bridge here connecting the middle frontal gyrus with the inferior frontal gyrus, and you can have more of these variations. What is important at the end is that you put all this information together into some kind of recognition system. So you apply this on the exoplane. The exoplane, you can use all four methods, and I think you should try to use all four methods together. You start with the one that's the easiest for you in this specific case. So if it is the motor hand area, that's fine. You identify it. You then check that this is opposite to the L sign, the superior frontal sulcus, precentral sulcus junction. You make sure that the sulcus you have identified by these two at the central sulcus goes into the pars bracket, and then finally that what you have identified at the precentral gyrus is thicker than the postcentral gyrus. Any order is allowed and is actually irrelevant. The important thing is that you use as many as possible. Some of them, sometimes, one or two will not work and you will be insecure, but therefore use the others. Sagittal is slightly different. You have one method for medial, one method for lateral, and one in the middle. So depending on your pathology and how comfortable you feel, you start with the one side, and then using your packs, you just hold your pen in a certain area and your cursor, and then move from medial to lateral or lateral to medial. Make sure you don't always stay exactly at the same point, because you know the central sulcus moves as you go from one slice to the other. So that's how you integrate the whole thing. Let's come now briefly to Heschel's gyrus. Heschel's gyrus is important because it is the primary cortical area. So you start here from the cochlea, there are a number of relay stations that finally take you here to Heschel's gyrus. So this is where its functional importance lies. It has been used as a landmark for quite a long time because a vessel typically forms with a very distinct shape around the gyrus of Heschel, and that was used in angiography and stereotactic approaches as a landmark, and also in MR, of course. So, on the axial plane, we choose the section where you have the two thalami coming together, forming the so-called adhesio interthalamica. And this is where you have, behind the insula, a gyrus coming from posteromedial and going anterolateral. Behind, going from posteromedial to anterolateral. In this case, it bifurcates at the end. If you give contrast, you will see here an enhancement of the internal cerebral veins. We just saw this for a moment. You see this one bifurcates at the end. This one here, you see, is one and a broader one behind, where one may not be so sure. Here you have clearly two. The first and second one bifurcates. Here you have two, seemingly connected at the convexity, and here a broad one with a small ramus or fissure in the middle. When you have more than one, it's always the first one where you have audition located. And the sagittal plane, typically you look at the temporal lobe and you see here this form on the surface. It has the form either omega or champignon. It separates the surface into two parts. Anteriorly here you have the planum polarum because of the temporal pole here, and behind it you have the planum temporale. And here behind it immediately is Heschel's sulcus. And you can have a small sulcus on it, and that's called the sulcus intermedius of Beck, giving it then a different shape. So here you have the insula, at the back you have Heschel's gyrus. Here you have the small sulcus on it, giving it the shape of bifurcation, maybe a heart. A lot of imagination is possible. Here you go more lateral, you don't have the insula anymore. You have 2 and even 3 on occasions. In the coronal plane, it has a similar shape in a way. It has a shape of an omega on the superior surface of the temporal lobe. The landmarks here are the tent-like shape of the fornices, and also, depending on the sequence you use, you can see here the 8th cranial nerve. There is a very distinct cytoexotonic area for Heschel's gyrus, which is here, according to Brodmann, area 41. Modern work from the group in Jülich and Düsseldorf, Professor Zillis and Professor Ammons, have shown that it is a distinct cytoexotonic area which has also some subdivisions, and looking at its variations you see that it's not identical. This is where you have this cytoexotonic field, the black part. It's not identical with Heschel's gyrus. It can be less and it can extend to be more, like here, to go beyond Heschel's gyrus. But it's always related to Heschel's gyrus, and therefore for our clinical purposes Heschel's gyrus is a very good landmark for the primary hearing area. And putting everything together onto one brain, you see they all have a central area in common. Red means most common area, blue means less common, and you see it is at the adhesio interthalamica going from posteromedial to anterolateral here on the superior surface of the temporal lobe, and here the same. In this patient, you see adhesio interthalamica, internal cerebral veins. You have a low signal on a gyrus that goes from posteromedial to anterolateral. You see the gyrus on this side. You give contrast, you see the developmental venous anomaly here, and you see on the coronal image the very dark signal, low signal in this area. Here you have it on the other side. So that's a cavernoma with an associated developmental venous anomaly within Heschel's gyrus, and the patient presented with epilepsy, but in her aura she was hearing music, and that is explained by the location of the cavernoma. So what is important, if we summarize this part, it's that primary audition, primary hearing is located in Heschel's gyrus, in the first one, if there is more than one. How to identify the section where to look for it: in the axial plane, it's the adhesio interthalamica. In the sagittal plane, has a shape, it's its own shape, the omega or heart, in the coronal, an omega. And keep in mind the variations of the cytoexotonic fields. The third part, the primary visual cortex. You remember what I said at the beginning of the anterior border of the occipital lobe, and on the convexity, and here on the medial surface. So let's look at this here in more detail. You have the parieto-occipital sulcus, you have the calcarine sulcus. They come together, and this anterior sulcus is now called the anterior calcarine sulcus. And because of its shape, Tom Nady called it the lazy Y. So that's a way of identifying it. Parieto-occipital is always easy to identify. You always can identify the anterior calcarine sulcus. The calcarine can be challenging on occasion. But you see the junction, and this is what helps you identifying calcarine sulcus. So you see the various forms. You can have a single peak, you can have more of a plateau, you can have S-shaped, or you can have double peak or triple peak. You can have a lot of options, but it can be difficult on occasion to identify the right one. So it is important to come parieto-occipital. Where is the junction? You see anterior calcarine, and this is where the junction is. The same here. You come here, this is where the junction is, so this is the calcarine. You come here, slightly more challenging, but it is here where you have the junction, where you have the anterior calcarine, and similar here, where you have the parieto-occipital, anterior calcarine, and here the calcarine sulcus. Calcarine sulcus, and the calcarine sulcus has on its borders a very typical and characteristic cortex, which has a second layer of myelination, which is therefore also called straight cortex. This second stripe are called after the person who described them, the stripes of Gennari. You can see them on histological staining, but also here at 9.4 T imaging. The visual areas cover quite an important part of the cortex. It is estimated it's about 20% of the cortex is dedicated to visual areas. So you have from V1 to V7, and some even called it, identified a V8, although this is contested, and most think there are usually only 7 cortical areas. The primary, the V1, is also called the straight cortex, as I mentioned, and you can see it with functional imaging. The visual cortex that relates to the other areas is called the extra-straight cortex. Can all be identified by fMRI. So looking at the variability of the cytoexotonic areas of V1, V1 is the physiological nomenclature. The cytoexotonic nomenclature refers to the Brodmann areas. Here the Brodmann area 17, which is the red. 18 corresponds more to V2, which is the green. And you see how much you can see coming out to the occipital pole. It can be quite variable. It can be a lot, as you see here, or can be much less. And the green can be rather thin or much more pronounced. And if you look at the sagittal plane, you have the same. You have here a little bit of red, a little bit here, and you can hear much more red, much more of the straight cortex on both sides of the calcarine sulcus. So these variations need to be kept in mind, and they are also associated with the variability of the physiological tests that allow one to identify V1. So I summarize this last part, which is that the primary vision is located at the calcarine sulcus, that the way of identifying it on the sagittal plane is to identify, to look for the lazy Y, and to keep in mind, again, like we did for Heschl-Gyrus, the variations at the cytoexotonic level of BA17. Thank you very much.